Yes, my name is Elizabeth Sellers, and I am one of the geneticists at Children's Hospital. I have two partners here, Dr. Jarati and Dr. Burrow, you guys may be familiar with, and then Dr. Schaefer, who was the predecessor before me as division chief, has moved to Northwest Arkansas, but still rotates call with us. So if you guys are paging us, you might speak to any of us. So I wanted to talk about something a little different today, rather than going through a bunch of syndromes you guys can Google and giving you the facts you probably already know or think you know. I thought I'd talk about genetic testing. It's something that's rapidly evolving very quickly, almost at a breakneck pace because of the money that can be earned with it, quite frankly. And so these are tests that you might be thinking about ordering, or you might be looking at results and trying to figure out what this means, what this was done, what did it and did it not test for. And so I kind of wanted to focus on this, giving a few examples of some genetic syndromes so you know what we would be testing for when we did these tests. So I want to talk about specifically these tests. So things you're probably familiar with: karyotypes, FISH, microarrays, looking at trinucleotide repeat diseases and testing for that. And then sort of our new range of tests, which is looking at single gene testing and then expanding that to looking at multiple genes, if not all of our DNA, basically whole genomes and whole exomes, because we are certainly at the forefront of this information. And then I think it's really important to include in that limitations of testing, the different types of results, which are so challenging for us, and then why we get consent for testing. So let's dive right in and talk about karyotypes. So this is certainly one of our oldest tests. And while it's old, it's not that old. So it was not until the 1950s that we even knew that there were 46 chromosomes. For a number of years before that, we, not me, but the global we, thought there were 48. And so once we were able to actually look at our DNA, things rapidly changed. For what's beautiful about genetic testing, I include this under karyotypes, but this is really for any of our tests, is that we can pretty much get any type of tissue and extract DNA from it. So blood is the easiest and has the greatest amount of DNA, the highest fidelity, so we prefer that. But you can get buccal swabs and saliva, you can get skin, muscle, tumors. Tumors have their own DNA, their own genome, products of conception from miscarriages, as well as all the fluid in the body as well. And then you can extrapolate that and actually start sampling this type of tissue in fetuses, which we'll talk about at the end. So a karyotype does involve, it's a little bit more labor intensive, it involves more humans than machines. But we certainly still do this for any number of diseases and for any number of reasons. So the key with this requires a cell culture. So you're actually relying on cells to divide, because that's when you're pulling out the DNA at those stages when they replicate it. And then you can manipulate them to string out the DNA or have it small. And then you can count just whole DNA, whole chromosomes, or you can look at banding. But you can get some mistakes in karyotypes because of the cell culture. You can get some random changes that are in one single cell just because of this process. So that's something I will make sure I teach students, because there might be one little random change that's just because of this process, and we don't worry about it. So there are actual humans that are trained in cytogenetics. I think they're brilliant because they take the gobbledygook on the top left. There's amazing machines attached to microscopes that allow them to pull out and separate chromosomes. They can literally just look at them and tell you if that's a 1, that's a 22, oh, that band looks like it's off. So they're highly trained to look at these and be able to separate them. Yes, very, very amazing. And so again, when you're looking at this, really, many times you're just counting chromosomes. Is there the right amount there, the right number? And then you can move on and look and see if there's chunks that are extra or missing potentially based on the banding pattern. So the longer you culture it, then the more bands you can get out of it. The more time you have to stretch the DNA and get a higher resolution for banding. So that's something to remember. So this is the type of test we would do. I like to lump together the diseases with the test because they kind of go hand in hand. A lot of times board questions when I'm teaching, it's 2 steps: what's the disease and what's the test for it. So whole chromosome changes are things like, obviously, Down syndrome. Our most common chromosome change would trisomy 21 in 95% of cases. So this is one that really you can clinically diagnose. The features are quite strong with this, but the test of choice is still a karyotype for this because how the chromosomes are arranged tells us about recurrence risk for the family. So when it's trisomy 21, that gives the lowest recurrence risk. If there's another arrangement, then that starts to modify the chance of this happening again in the family. So this is one where there's still a huge range of findings with this syndrome. I will caution anyone who meets a sweet family to say that their child looks to have a mild case of Down syndrome. We don't measure it in mild, medium, and hot. You either have it or you don't. You either are or are not pregnant, you are or don't have Down syndrome. So, because it's really hard for us if they come in and say, oh, it looks like such a mild case. So we like to say, oh, you do or don't have these features of Down syndrome, but there's no way to predict cognition and language in a new baby. So I feel like the media likes to portray a very high functioning person as the norm for Down syndrome, the one who lives independently, rides the bus, and has a job. In our patient population, that is not the norm. That is someone on the very high end of the spectrum. So there are a number of patients who still struggle with language, still struggle with feeding and have G-tubes, and that is often more of the norm. So we kind of like to, set them up to not have expectations that they will fail. So 50% have heart defects. That's why an echo is often the first test. Hearing and vision are commonly compromised. So if a question asks what's the most common thing, then hearing and vision is often the answer. Leukemia is in a very small percentage of individuals, but is obviously the scary word that families will see. So we certainly talk about that and try to help their fears with that. When we're talking about the genetic changes of this, again, 95% of cases are due to non-disjunction, where an extra chromosome just rides along with the other one, so that's what happens. In this case, it's often maternal meiosis that this occurs. We know that, again, as we all know, that there is an age-related risk to this, but because most people having children are actually young, most of my parents are young. They're not older women. The other 5% of cases often are Robertsonian translocation, so where a parent is carrying a balanced amount of DNA, but it increases the risk for passing on an extra amount of DNA. So that's the case that we rule out with our karyotype because that changes that recurrence risk. Mosaicism can happen in this, and that's what all parents seem to cheer for, even though I truly don't necessarily see a milder form of this and we don't take care of it any differently, but I rarely see that, so it's not very common. Turner syndrome, which I know has been mentioned before, we share these patients often with endocrinology. These are girls that often, I would say, enter the medical system at a number of different points. These can be some of our sickest babies in the NICU because of really complex heart disease and lymphadenopathy. These can be girls who start school and their short stature really is exacerbated. These can be girls who have late puberty, as you guys just heard about. So they might appear at any point in time. Again, there's no core feature for this. There's a wide spectrum. We do see things, again, like the amenorrhea, the short stature, heart disease. If you're ever worried about a genetic syndrome, and I'll give you a hint and you call us, we'll probably say, look at the heart and kidneys. Those just seem to always be involved and give us clues. These girls tend to have an overall normal IQ, but it's skewed. They tend to do better with verbal than nonverbal abilities. They have a great problem with spatial relationships like math. I have a number of girls who have a really hard time learning to drive. So they have just sort of some distinct characteristics about them, but certainly can do well. So this one's a little bit different. Only about half of cases are due to non-disjunction, and this is actually an error in paternal meiosis rather than maternal. This one has a much higher incidence of mosaicism with it. We don't know why, but we certainly see that, and again, still gives a wide bit of variability even with that mosaicism. This is also one where the remaining X often is structurally different. It often is a ring, it gets stuck to each other, and when that's the case, there's a lot more significant learning issues with that. Sometimes there's also the single X and then a little tiny piece of a Y. It's a marker chromosome, and that increases the risk for gonadoblastoma, so we do some screening with that as well. And again, that's why we get a karyotype with this. Not any other test, just a karyotype. The SHOX gene is located on both the X and the Y. When this X goes missing and there's only one copy of it, that's really what seems to lead to the short stature. So you're only encoding that one copy. And then also note a huge 1 to 2% of all conceptions end in this 45 exo, and a large number are miscarried. So when we do test products of conception, this is often the result we get. So Klinefelter, I wanted to mention this as well. Again, we're lumping together all our whole chromosome changes. This is one where rather than having the missing sex chromosome, there's an additional X chromosome. This one affects boys. Again, now you have more SRY presence, so we see tall stature with this. We typically don't see a lot of features in childhood with this. This is one that is more prominent as individuals get older, which is challenging because more and more prenatal testing is identifying this, and there's not a whole lot of worry early on, but you have parents who are now panicked. So we're still trying to deal with that in our genetic counseling. Okay, moving on to, I'm just going to briefly talk about fish. It still lurks out there in our vocabulary, but we're really not doing this much in pediatrics, in clinical practice. This still lives largely in oncology and sometimes for some rapid testing because you can really quickly count things with this. This was in the early 90s, and the idea of this is that you're creating a probe to stick to a piece of a chromosome. So you're designing what you want to look for. So you think about it as designed to stick to the centromere, really quick count chromosomes, and you know you have the right number prenatally, for instance. Or do you have an extra 13 or 18, you can count X's and Y's. This is also something where when you're looking for certain combinations with oncology, you might design a probe for that. So that's really where this exists now. It doesn't give you the fine-tuned answers for most of our syndromes that families are looking for. So we don't use this to make a lot of diagnosing for our syndromes. But it's really fast. It doesn't require that cell culture we talked about earlier. So that's the advantage of this. This is what you kind of get as a result. So you can see you're looking for that fluorescence so you can count things. This was a probe designed specifically for the locus for Williams syndrome. You only saw one. I know this is a lot of words thrown at you, but I think you might have seen them at times. So I wanted to just give you a chance to hear what they are. So SNPs, we've kind of all talked about from that remote biology class or genetics, and those are literally single nucleotide polymorphisms. So where one letter turns into another letter, a T becomes an A. We really have tons of these, tens of millions of these in our body, and we know that a lot of this is what makes us unique because we get a combination from our mom and our dad. Caucasians have a certain pattern of SNPs, African Americans, people from different regions of the world. It's really a lot of what embeds ethnicity into us. In some ways it can confer disease susceptibility, but SNPs are not disease causing. Okay, and so I want to jump to something that's come up a whole lot lately. Endocrine has actually asked me recently about this. I've seen this a ton in questions from pediatricians and lots of practices, and this is Mthfr, which stands for a really bad word, but it also stands for a gene. So it stands for the methyl tetrahydrofolate reductase gene, which is an enzyme. It's here in this pathway, which looks super complicated and already makes you want to harm yourself, but it's basically an enzyme that turns folic acid into different forms of folate. So already you're pinging folic acid. And then already if you are going to make money, you're going to design a really special vitamin that has special folic acid in it. And then you're going to test for this and tell someone they have a disease and sell them a vitamin. And that's what we're seeing. But so there are two common SNPs in this gene, two common polymorphisms, which I've listed up there. So the key to take home, if nothing else, is that these are extremely common. 25% of Hispanics and up to 15% of Caucasians carry two of these SNPs. And yet 25% and 15% of people don't walk around with significant disease that this is trying to link itself to. So it's linked to disease because it's so common. The only thing there is actual evidence that this does is in some people raise their homocysteine level at some times. That's it. There's nothing more. So it's been originally linked to some idea of blood clots, but even that seems to be a very small risk. So my college, the American College of Medical Genetics, and ACOG, the American College of Obstetrics and Gynecology, actually have statements saying do not test for this. It does not mean anything. There's no way to advise patients. So it's out there because it's popular. There's a lot of profit to be made with this, but I will tell you the evidence-based medicine is that this is not a disease-causing gene at this time. There is no evidence that we can find. So back to the microarray. So in addition to chopping up DNA into small pieces and scanning them, we also can look at SNPs on the DNA. And what this tells us is how similar the DNA is. Therefore, is there any way that the relationship of the parents can be related? So this tells us consanguinity, basically. This tells us similarity between the DNA. And so because of the power of now what all we can get in a microarray, we do get a consent for this when we get this test. We talk about the types of results we might get, the fact we could find a change that's unintended, and the fact that we can tell relatedness between the family. So that's what we go through when we consent for families. So microarrays, as you can imagine, this is kind of like a bunch of fishes together, but it gives much more information than a bunch of fish tests ever could. We basically don't have to rely on cell culture. We can just immediately start loading this. And again, we can tell that similarity between the DNA, which is heterozygosity. It gives the power with all of that. What it doesn't do is tell us if there's a balanced rearrangement. So this is not the test for Down syndrome. It doesn't tell me the arrangement of the DNA because it's chopped it all up. It doesn't tell me if there's a balanced translocation in a mom carrier. It doesn't tell us mosaicism below 20%. So if there's just a few cells floating around that are abnormal, it's not going to pick up on that. So a few examples with this, 22q deletion is the most common microdeletion syndrome. Again, my plea today will be just to call it this. Don't call it anything else. You will be far above our cardiologist and our immunologist if you call it this. Before we knew the genetics of it, it was described as independent diseases. The heart part was VCF, the immunology part was DeGeorge syndrome, and then Dr. Sprinson called it his syndrome. And then once we were able to do the genetics, we realized it was all the same darn thing. But it's still those names float around, but when you say the names, you kind of confer a certain phenotype you may not be meeting. But 22q deletion just tells me this is missing and anything could happen. This is also one where it's the number one cause of palate defects, and it's so common that this could occur with another genetic syndrome. This is one where we don't have a unifying diagnostic criteria. This is another entry point into the hospital through ENT, cardiology, immunology. They could present any number of ways, so it has to be on the radar of a lot of different doctors. It also has short stature, developmental delay, and a lot of health issues with this. The reason why this often gets deleted is because flanking the DNA is the same repeat over and over, so it has a hard time lining up during replication and often gets flipped out or even flipped in. We see this as a duplication quite often as well. And this can certainly run in families. I'll mention Williams syndrome, we looked at that earlier, that's on chromosome 7. Again, no unifying features, you'll see the common theme of heart, short stature, and calcium can be another issue with this, again, often shared with my endocrinology colleagues. There's nothing significant to do at first except for monitor, again, heart, calcium, growth, things of that nature. I'm quickly going to hit on trinucleotide repeats. The main point I want to make about this is that without testing for these types of diseases specifically, no other genetic test picks up on it. So if you have a boy with significant delays, you have to do a Fragile X test. Nothing else will pick up on it. If you are worried about ataxia, there's a lot of single genes that are for that, but then there's also a trinucleotide repeat, so you have to test for those. Your genetic test otherwise won't. So this is one where a lot of times you have to remember what you haven't tested for yet. With all of these, PCR is what is initially used because PCR can detect if it's normal. If it's abnormal, we have to do a Southern blot to get the actual number of repeats. So it's a little labor intensive. And I'll mention Fragile X, just really what I'm going to say about Fragile X is we don't really have this in Arkansas. While it's definitely reflected in the literature as the most common genetic cause of inherited mental retardation, it's enriched more in the East Coast. We just don't have it. I've been here almost 8 years. I've diagnosed it twice, and I test literally everyone for this. So while it's something to mention, I tend to tell families not to worry about it because I just don't see it. Okay, now moving on to really what is now on the forefront, which is gene sequencing. So what we initially knew was single gene sequencing. So when I'm worried about Marfan syndrome specifically, or achondroplasia, then I test that single gene. Again, microarray, karyotype, fish, they're not going to pick up on that. I'll have med students who say, hey, we did that microarray, we looked at everything. We didn't look at any single gene. So that's why this is a test where if you know what you are specifically concerned for, we certainly still have single gene testing out there. And this is to look for specific point mutations. In 1977, the technology was developed, which is Sanger sequencing. Again, literally just coming out with each letter in a row and then figuring where there was a change. Well, as you can imagine that over time, as with the microarray and looking at big data all at once, the idea was, well, what if we could sequence a whole lot of genes at once? What if we could look at the whole genome or the whole exome? And we started realizing that that's where probably we needed to be moving, but the technology needed to catch up, which is where the idea of next generation sequencing comes in. So if you have seen results or seen us order an NGS panel, or we talk about giant genetic panels, that's using this technology. This is what has basically allowed everything moving forward to occur. And what this is essentially think of the microarray where you chopped up your DNA into small chunks, and then you sequence those chunks thousands and thousands of times. You don't care where the chunks are, you're just sequencing all of them. And then you lay them all on top of each other such that you can get the entire genome in a row.
So you have chunk after chunk after chunk after chunk, and you line it up, and then you get your whole sequence.
So it's rapid, it's high fidelity, and you get all this data, all this information. And so that's great, but sometimes you don't want all of that information. So that's where we put on filters. So you might pull out all the exons, or you might pull out all of the genes related to a skeletal dysplasia. I just want to look at the skeletal dysplasia genes, or I want to look at the cardiomyopathy genes. So all the data is still there, it's just you put on filters and just pulled out what you want. And that's what next generation sequencing is. That's what these big genetic panels do. So again, you can look at one gene with this, you can look at 20,000 genes with this. And a lot of times we do like when there is a specific phenotype that's present, really just looking at genes related to that. It's a lot less noise. So the problem is the results get more and more complicated, as you probably have seen. In fact, before we didn't even have standard terminology about what to do with the results. Some people were using the word polymorphism, like we talked about earlier with Mthfr, and some people were using a mutation. And so my college, again, got together and said, okay guys, we've got to standardize this. And so we essentially, I mentioned this, came up with this. I like this visual, where I really think that there's three buckets. There's the benign and likely benign bucket, hey, don't worry too much. There's the pathogenic, likely pathogenic bucket, hey, I think we've got an answer. And then we have my favorite result, not at all, the, oh shit, I don't know what this is result. The variant of uncertain significance, the VUS, right? And so that's one where we just don't have enough data. It's not that it won't get reclassified. We absolutely are seeing reclassification of these results, but it means at this time, there is not the data present. In your patient, it might look like the answer, or in your patient, it might in no way explain anything, but there just isn't data. And that's what that means. Nothing more, nothing less. The other thing is all this data, especially if you don't put on filters, leads to secondary findings. Meaning, yes, we're looking at all the genes, and you're just worried about your NICU baby, but we also happen to look at the breast cancer gene and the colon cancer gene and cardiomyopathy genes. And do you want that information or not? So the ACMG, my college, has come up with 59 genes that by detection early on, there is additional monitoring or even treatment, and it's optional if you want that information or not. So that's why these big tests, again, have consents. We go through them and we try to educate parents about what is involved. This is just a sampling of some of the genes. A lot of the ones up here are heart genes. So again, by additional monitoring for an arrhythmia, you might prevent sudden death. Last topic, I want to hit on cell-free fetal DNA, or NIPT testing. Again, those of you taking care of new babies might see that there was some testing done early on. What does that mean? This is pretty recent. This is in the last decade. We've known for some time that whole fetal cells pass from fetal and placenta circulation to maternal circulation, but they were really scarce. They were very hard to pull out. You'd have to pull out 20 mLs of mom's blood to get hardly any, so we couldn't really do anything with them. We also knew that after the baby was born, they persisted in mom's circulation, so if mom had multiple pregnancies, you didn't actually know which fetus this was. So we couldn't really do anything with them. But equally creepy is the idea that fetal, just pieces of DNA, also float in mom's blood from the fetus. So let's see, we've had pieces of DNA. What does this sound like? What could we do with this? Wait a minute, we have next generation sequencing, which takes pieces of DNA and sequences them into thousands of fold. So suddenly now we can take mom's blood, not an amniocentesis, and pretty reliably look at the fetal DNA. And that's essentially what this is. It's non-invasive prenatal testing, though mom might say it's a little invasive. And this was much better because this was present early in pregnancy. By 5 to 7 weeks gestation, we knew that it was much higher presence than whole cells, and we knew that it was cleared after delivery so that you could really just be looking at this pregnancy. Now, of course, if mom has a tumor, then that's also floating in her DNA. So we had consent for this as well because we've certainly diagnosed some women with a disease for themselves from doing this. But again, it uses the same technology we just talked about and essentially counts DNA. It counts the number of chromosomes present. This is still considered a screening test, so the recommendation is to follow this up with a diagnostic test, such as amniocentesis or testing the baby after the baby's born. I have certainly seen false positives and false negatives with this. It's not a perfect test. It's not billed as a perfect test. And here's just a depiction of that. You can see the combinations of DNA floating around, and then on the right, the box is just the idea is it looks at ratios presence, because it looks at mom's presence of DNA, which is a much higher number than the child's. So just some takeaway points. We talked about tests that can give you a lot of data, but bigger is not always better. There's confusing results, unintended secondary findings, so we really thoughtfully approach this in genetics and have a good conversation with the family about what they truly want. We also do PAs. Private insurance excludes genetic testing and those codes many times, so it's not something you willy-nilly order. We have a whole process for getting a PA and talking to families about the out-of-pocket cost for them. We talked about the complexities of results, that they're not always black and white, but you can find these uncertain answers as well. We also know that there's the ability to opt in and opt out of information as well. So I know that was an overwhelming amount, and I apologize, but I feel like you see and hear about so much of this, and maybe putting it together a little bit, especially if you can take home the slides, would be helpful. I'm so happy to answer questions after this, and I'm always available via page if ever there's questions. So thank you so much for your time.